Good evening.
Good evening, ma'am.
So, what time are we starting?
Just in a minute, ma'am.
Okay, fine.
Are we live now?
Yes, ma'am. Now we are live.
Yeah. So, good evening and a warm welcome to one and all for the Thyroid Clinic session. We are thrilled to have all of you with us today for this informative session on thyroid health. So, before we start today's session, there will be a brief video of the Indian Thyroid Society, which represents the society's mission and its aim in achieving thyroid health. So, I request the IT team to display the video.
तस्य भासाय सर्वमिदं विभाति.
The thyroid clinics, the Wednesday special thyroid clinics organized by the Indian Thyroid Society is being held every month. So it's being held under the leadership of our distinguished coordinators, Dr. Pramila Kalra Madam and Roma Pradhan Madam. So also we have Dr. Krishna Sheshadri sir, who is the president of ITS, Dr. Arun Menon sir, the secretary, and Dr. Mini ma'am, the treasurer, who have always been guiding us. And for the thyroid clinics team, we have Dr. Chitra madam, Dr. Vijay sir, and myself. So all of us are organizing this thyroid clinics every month, organized by the Indian Thyroid Society. So today's session, so before we proceed, we those who are interested to submit their journal, their articles to the Thyroid Research and Practice, which is the flagship journal of the Indian Thyroid Society, can do so by scanning this QR code. And those who are interested to become a reviewer can also do so by scanning the QR code displayed in this particular slide. So, moving on to today's session. Today's session, we have a very interesting case presentation by Dr. Suprabha Chowdhury. The case is on a timely surgical intervention which saved a patient with a complex thyroid nodule. And to moderate the session, we have Dr. Amit Agarwal sir and Dr. Swati madam. And moving forward, we have a very interesting talk on the management of subclinical hypothyroidism in children by Dr. Kaushik Pandit sir, and followed by a very engaging quiz by Dr. Sonali. So, before we proceed with the session, I request Dr. Roma Pradhan Madam to introduce the moderators for the case presentation.
Yeah, a very
Over
good
to
evening
Roma,
to
ma'am.
all. A very good evening to all. I would like to introduce the moderators, Professor Amit Agrawal sir, who's Director, Breast and Endocrine Surgery at Medanta Hospital, Lucknow. He needs no more introduction because he has already taught all the MCH students in the country. So, and he's also my teacher. Then Dr. Swati Jadhav, who is a consultant endocrinologist at Trustwell Hospital, Bangalore HCG Hospital, and a lot of achievements to her too. So before, without wasting time, let's start with the presentation. Dr. Suprabha, are you there?
Yes, ma'am. Yes, ma'am.
Yeah, she's a senior resident at a department of breast and endocrine surgery at Medanta Hospital, Lucknow. Suprabha, can you share your slides now?
Yes, ma'am. Can everyone see?
Yes, yes.
So I'm going to share discuss interesting case of timely surgical intervention, how timely surgical intervention saves patient with complex thyroid nodule. A 32-year-old female was referred to Department of Intervention Radiology at Medanta, Lucknow, for radiofrequency ablation of 5.2 centimeter right solitary thyroid nodule, Thyroid 2 on USG, with few subcentimetric lymph node in bilateral cervical region, for which the ultrasound guided diagnostic biopsy was done and was reported as papillary thyroid lesion without any nuclear features of papillary carcinoma. This is the ultrasound picture of the right thyroid nodule, which was about 5.2 centimeter. The thyroid profile of the patient was TSH was 1.2 and T4 was 1.1 and free T3 was 4.3. Further, a USG guided fine needle aspiration was done, which was reported as Bethesda category 3 and which is also known as ATP of undetermined significance. After further evaluation in endocrinology department, patient was referred to us in endocrine and breast surgery for surgical management. The patient was planned for right hemithyroidectomy with frozen section biopsy of the lobe as well as the lymph node in view of the short history and recent increase in the size of the. After adequate preoperative evaluation, the patient was taken up for surgery in view of suspicious cytology, as the ultrasound guided biopsy features were suggestive of papillary thyroid carcinoma. We did total thyroidectomy with central compartment lymph node dissection, right selective lymph node dissection, level 2 to level 5A with intermittent IONL. Intraoperatively, right lobe was grossly enlarged along with the multiple enlarged lymph node in the right central and lateral compartments. Frozen section analysis of the right lobe revealed that the entire lobe has been replaced by primary thyroid carcinoma, while the lymph node in the right lateral level 2 was reported as positive for malignancy. However, the lymph node for the left lateral compartment was reported as negative for malignancy. So finally, the surgery performed was total thyroidectomy with bilateral central and right lateral level 2, 3, 4, and 5A compartment lymph node dissection. This is the right lobe, the lymph node, the intraoperative picture. Post-operatively, the patient had normal voice and was able to accept liquid on the evening of the day of the surgery. However, the patient developed biochemical hypocalcemia on post-operative day 1 and was managed with intravenous calcium boluses and oral calcium with a remedy and discharged with a calcium and vitamin D supplements. Post-operatively, patient was discharged at day 3 with a calcium level of 8.5 milligram per TL on calcium and vitamin D supplements. The histo showed right lobe papillary thyroid carcinoma of classical type of 7.5 into 4.5 into 4 centimeter without any capsular or vascular extension. In central compartment, out of 16, 10 lymph nodes were positive for malignancy, and in right lateral compartment, out of 26, 12 lymph nodes were positive for malignancy. So we staged that as stage 3 cancer, and then was planned for whole body radioiodine therapy. Thank you.
Thank you, Suprabha, for your presentation. So I think the case was chosen for discussion because in today's time there is a real threat to the proper or optimal management of the patients. Interestingly, the first slide as shows the patient was referred to the intervention radiologist for management. Now, the patient did not seek consultation with the endocrine surgeon or with the endocrinologist in the hospital. He was directly referred because perhaps the intervention radiologist touts as a thyroid specialist who can manage without giving a scar in the neck, non-surgical management. I'm sure others would be having the same experience. Dr. Swati, would you
Yes.
share your
In
experience?
Actually, not for this case, but otherwise also endocrine, it's very difficult for people to understand and reach us at the right point of time, whether it is medical endocrinology or surgical endocrinology. Having said that, there are several things in this patient's management which tell us that they are not at par with the, at least the terminology which we commonly use nowadays, the pathologist, the cytopathologist, the USG. I mean, the kind of the first slide where the it was reported as papillary thyroid lesion without nuclear features of papillary carcinoma. So it gives a very mixed picture. So I think the Bethesda 3, as we understand in 2023, it has been Bethesda category 3 has been subclassified into nuclear atypia and atypia otherwise. With this description, I feel there was no nuclear atypia because they have written there were no nuclear features, but at least there was a lot of papillary structures. So there might be architectural atypia in this patient, but the sheer size of the tumor, I don't think I mean, at least I wouldn't have sent for interventional radiology with that size of the lesion. It was,
So
I,
this was referred by a general physician. So
uh,
imagine patient goes to his GP, and
yes, yes,
he perhaps has known about a intervention radiology doing ablation, you know. So he was
yes, yes,
directly referred to the intervention radiologist. So that is one thing in the society is being perpetuated that non-surgical treatment, which is less invasive, can be performed by intervention radiologists who don't have training in thyroidology at all. So that's it's very concerning. The second point is, he got a true cut biopsy done, You don't get a true cut biopsy in thyroid lesion. That papillary that was histopathology on a true cut biopsy.
okay, 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 fine,
Data
sir.
from the FNAC was Bethesda 3.
Okay. So general
Yeah.
understanding among the interventional radiologist is that at least they need two FNACs to be proven to be Bethesda 2 before they even consider for that.
No, no,
So,
they are doing even for papillary carcinoma also.
okay.
They are
Oh,
ablating even papillary carcinoma also.
okay, sir.
Now imagine this patient had an advanced malignancy with lateral lymph nodes 12 out of 20 and
Yes.
central lymph nodes 12 out of 14 were positive. Now, this patient would have undergone an ablation. So imagine he or she would have come back to us with aggressive carcinoma, recurrent carcinoma. So this is a real threat because the intervention radiologists, with all due regards and respects, they don't have any idea about the thyroidology.
Yeah, that's true. And even the sonographic description, I mean, that bigger lesion, I think it's isoechoic. So, and the margins also are apparently irregular in this. I
Yes,
mean, it was not a good looking thing right from the beginning, the way it looks and the way it has been described on FNAC. So, surgery would have been the upfront, um, I mean, it should have been the dialogue with the patient.
definitely. So the
Mm.
patient luckily sought the help of the endocrinologist who rightfully sent it to us. So patient was lucky that she was managed properly.
Yeah. So, sir, just for the point of discussion, in with the now availability of molecular markers, Bethesda 3 is something which we would go in for for molecular markers, but particularly for this patient, the way the size of it is and the way it is looking overall, I don't think even we would have considered molecular markers. Surgery would have been a very lower threshold for us to refer to.
Oh, that's a good point. But the kind of profile patients, which I'm sure you must also be seeing, they like to be sure about the preoperative diagnosis. So
Yeah.
they would want to know if we can do anything to further, confirm whether it's malignancy or not. So perhaps a molecular marker, if they can afford it, they would like
Yeah.
to get it done. And in our practice, I think in India, perhaps we have ThyroTrack, which is available,
Yeah.
which may not be sensitive enough, but at least we can take the help of the molecular markers.
Yeah. Yeah.
Surgery with you, because of the size, of course, surgery was needed. But therefore, we did a frozen section because we had a very high suspicion for papillary carcinoma. And it turned out to be PTC. We did a total thyroidectomy and a neck dissection as well.
Perfectly well, sir. That's what I wanted to make a point, that if I had done a molecular marker in this patient, whatever is available, and even if it would have come as benign, I wouldn't have had the courage to tell the patient, just observe it for more than. Uh, I wouldn't have had the courage to tell the patient to observe it indefinitely. I would
Right.
have still, in my dialogue with the patient, I would always had been a little pro towards surgery for this kind of picture that it is.
So now this brings me to another aspect of this case brings out another aspect, and that is, should we as endocrinologists and endocrine surgeon be doing ablation, because we know thyroidology much more than the intervention radiologist, and I'm sure most of us are doing our own ultrasounds. So we are well versed in doing an ultrasound, and ITS always has an ultrasound course uh,
Yes.
for delegates and for postgraduates and young faculty. So
Yes.
most of us are trained in ultrasound. So I think we are placed in a much better position to do ablation, whether it's a microwave ablation or RFA, rather than intervention radiologists who may be good at radiology, but they have no understanding about the functional aspect of thyroid and how to follow up these patients. So what's your thoughts and role?
Definitely, sir. If there can be interventional cardiologist and dealing with such complex vasculature, thyroid, I think is definitely doable. Appropriate as a Indian Thyroid Society, if we make appropriate, what to say, resources available to the trainees, definitely this is doable, sir, and it will benefit the patient a lot. So the case shows that there is so much of differences in the language in which the healthcare providers are talking to each other. The
That's another important
cytopathologist,
point.
the
Yes.
sonography. If it is done by us or by endocrine surgeons, there won't be such kind of discrepancies in. I mean, there would be better patient management, and there will be better data collection also, and there would be better chances of analyzing it and learning from our own data then.
Yeah, this is very important. We have to talk in the same language so that the patient understands better, rather than confusing the patient if we talk in different language. So the format perhaps should be more standardized. Unfortunately, in India, the
Yes.
radiology and pathology is not very standardized as it should be, and that is why we are not able to follow the non-operative management for small PTCs, which is being done in many countries
Yes,
now.
yes, yes. That's true. That's true, sir.
Yeah, so
So,
one point in this presentation is for the students, especially that true cut biopsy is not indicated for these thyroid lesions. It's only indicated for anaplastic and lymphoma if you have a confusion. So this should be clear, no true cut biopsy. It was difficult for us to explain the patient why true cut biopsy was done because it was not ordered by us. So that also is a point, and everybody should make sure that do not advise true cut biopsy for any thyroid lesions at least.
True.
definitely.
So the president and secretary there, I think ITS can, have a brainstorming session whether who should be doing the ablation, because a lot of patients are demanding. Let's accept the fact that it is
Yes,
very tempting for the patients to go in for a non-surgical management for small nodules, uh, especially benign nodules. So we should have some sort of a white paper as to who should be doing these ablations, if at all patients want it.
sure, sir. The point well taken.
In your place, are the intervention radiologists doing the ablations? Do you get
So,
patients who want ablation?
so in not in my institution that they are doing so much, but definitely in Bangalore there are a lot of centers. The problem is they never come to us. I mean, the patients who undergo ablation, they would not turn back to us as
Yeah.
such.
Yeah.
So the question is, do we refer for ablation? Those patients are very, very rare. I mean, very cosmetically concerned ones and absolutely a cystic lesion, basically, for aspiration. And those are the ones which I refer. But the patients who, I mean, the interventional radiologists who are there in our institution and or they have their practices outside and they do ablation, but the patients don't come back to us as such. So that answer I won't be able to give you in terms of exact numbers. as to what is the current trend in practice actually for the thyroid nodule patients.
Right. Yeah, but this trend is catching on. In
Yes,
last
yes,
1 year of my practice here in Medanta, I've seen a lot of patients, especially doctors, who are cosmetically concerned. They
yes,
would,
yes.
want to know who does the ablation and where they should go for ablation.
Yeah, that's true.
So, in fact, I am part of a group of ablationists, if you can call them. So there are
Is it?
intervention radiologists and there are surgeons and endocrinologists. It's an international group, and they are ablating all parathyroid adenomas right and left.
Okay, parathyroid adenomas.
Big
Yeah.
adenomas with the calcium of 14 and PTH of 1000, they are ablating.
Hmm.
So that's actually a difficult situation because the radiologists, they actually do not know about the parathyroid glands much, what it can do. So, but still we have to be careful with whatever we are doing.
Yeah, I think
And
patient public awareness is very important, and we need to tell them that, ablation may sound very tempting, but it's not error-free or not complication-free. That's important. And not all nodules need to be ablated, especially if it's papillary carcinoma. We have to see whether lymph, because once you ablate and you have not done a proper exploration, you don't know whether the lymph nodes are positive or not. They don't undergo radioiodine scan, nothing. So I would, call them that they are really being mismanaged if all PTCs are going to be ablated.
Sure, sir. And as you rightly said, if as an endocrinologist or endocrine surgeon, if we get trained to do these procedures, we'll better triage the patient. Which
Definitely, definitely.
patients may actually, benefit by ablation, because we can't deny the fact that endocrine surgeons, if there is endocrine surgeon, I won't think twice about before referring the patient. But in tier 2 cities, tier 3 cities, where less trained people, general surgeons, or where ENT surgeons do perform thyroidectomies for a very benign lesion, just for I mean, they come to us for management of hypoparathyroidism after that.
Yeah.
So in that scenario, in those situations, if we are the ones who manage it by ablation, or if we triage it properly, then it makes a lot of difference to the patient management.
Yeah, exactly. So that we need to move from ultrasound workshops one step further, and perhaps have ablation workshops and ITS meetings to train our endocrinologists and endocrine surgeons. As you said, we can triage better, we can follow up better, we can, do a better job both technically as well as because we know the physiology, the anatomy, and how the patient, you know, I mean, endocrinologist knows best about the TSH and thyroxine tablets and Theranorm tablets. So nobody knows better than the endocrinologist. So we should not let the intervention radiologist, just by the virtue of the fact that they are better at ultrasounds and intervention, that they take away this aspect of thyroidology.
Sure, sir.
Any
Any
questions?
further comments?
Yet, ma'am.
no questions?
No, not yet.
So Dr. Ganavi, we can proceed to the next session there.
Sure, ma'am, sure. I thank Dr. Suprabha for her excellent moderation and presentation as well. And Dr. Swati Madam and Dr. Amit Agarwal sir for their valuable insights and moderation as well. So, moving on to our next session, that is the monologue on subclinical hypothyroidism in children. We have Dr. Kaushik Pandit sir as the guest speaker for today's session on this particular topic. Sir is the Chief Consultant Endocrinologist at Bellevue Clinic, Kolkata, and Sir is the Research Scientist at the Department of Endocrinology, IPGMR, Kolkata. Sir has numerous degrees to his credit. Sir is a DM endocrinology, has FACE, FRCP from Edinburgh and Glasgow, and also FICP as well. And Sir has numerous achievements also to his credit, including the Albert Renault Fellowship from the European Association of the Study of Diabetes. And Sir has more than 50 publications, both in national and international journals. And Sir is the author of many books and chapters on diabetes and endocrinology. So over to Dr. Kaushik Pandit, sir, on this very controversial topic, whether to treat subclinical hypothyroidism in children or not. So over to sir.
Good evening, everybody who has joined, and respected seniors in the group. Thank you, Dr. Ganavi, for your kind words. So just allow me 1 minute to just I hope this is visible. The slides are visible. Well, we have been talking about subclinical hypothyroidism as a very controversial chapter in the adult endocrinology. But when we talk of subclinical hypothyroidism in children, this is also very important, simply because of the fact that the period of growth is included there, and thyroid is a very important organ in influencing growth. So it is very important to understand whether subclinical hypothyroidism is a very important entity so far as treatment for hypothyroidism is concerned at this point of time. Now, if we quickly go through the definition of subclinical hypothyroidism, we'll know that subclinical hypothyroidism is defined as having an elevated TSH and a normal free T4 levels in the blood. So thereby suggesting that the degree of thyroid failure is not very high. It has not gone into what we technically call as overt hypothyroidism. Probably the thyroid is not functioning to the needed extent, but still it is suboptimal, and probably it also have got an effect in the whole body metabolism. But at this point, we must also be aware of the fact that age-specific TSH range need to be looked into. It must be, honored in the sense that TSH is something which is not sacrosanct so far as the level is concerned at different points in time. I mean, in the sense that a neonate with a TSH of 15 or an adult with a TSH of 15 has got completely different meanings. So the age-specific TSH range would be something that we really need to focus on that. Talking about that one, we'll know that if we look into the distribution of TSH level throughout one's life, we'll understand that, of course, it follows like various other parameters as a normal distribution. And this normal distribution, we'll see that the TSH may be pretty high at the time of birth, and it then gradually goes down over months and reaches a level of around 5 to the tune of approximately 1 year. And then from then on, it remains more or less something like that. But we are also looking into this chart. It is evident that at this is the normal distribution during near birth. This is the median, and these are the two extremes. So level of say 0.5 to say 18 is the distribution at the point of delivery, at the point of birth. Since then on, the upper limit decreases gradually, as you can see, and it reaches approximately roughly at the time of nearly 1 year to reach a upper limit of approximately 8 and a lower limit of approximately 1. So that's how it is distributed at the very early part of life. And then on, once again, there is inexorable decline of the upper limit, and it goes to the tune of say 5 years to the tune of say approximately 6, and then also follows down with time. So somebody who is having a TSH somewhere here is considered to be abnormal and probably needs to be taken care of with sufficient degree of urgency, rather than somebody who is this is the median. So somebody who is placed somewhere here who is around 75 percentile, a little elevated but still within the normal zone, has to be considered as normal. So our basic focus would be somewhere around, say, in this region. So somebody's TSH who is retaining in this region, what do we need to do? Now, in an age range of 8 to 18 years, there is no controversy if the TSH remains more than 10 microunit per liter, which is certainly much more than what is expected in this range. And in this situation, we are completely aware of the fact that there is a very clear message coming from the pituitary saying that the thyroid hormone produced by the thyroid gland is suboptimal, and therefore it is onerous on the responsibility of the treating physician to supplement the person with levothyroxine from outside to make matters in a completely euthyroid state. But if the TSH remains somewhere around, say, upper limit of the normal to the tune of, say, 5 to 10, or better, 4.5 to 10, then we are at a fix. Now we'll have to look into the free T4 level. If the free T4 is normal, then we'll know that this is something what is known as subclinical hypothyroidism we are dealing with. And this is where we need to rack our brain to know what we really need to do. If we go into the epidemiology or how common it is, we know that subclinical hypothyroidism in adults is somewhere between 4 to 20% in the population and is predominantly seen mostly in females. Whereas subclinical hypothyroidism in children is much less common, to the tune of approximately 2%. So what are the problems of having a subclinical hypothyroidism in children? Well, it is thought that having a long-standing untreated subclinical hypothyroidism in children probably have got an impact on the cardiac function, especially the having risk of hypertension later on developing in life. And some study had shown some ventricular abnormalities associated, rhythm abnormalities associated with subclinical hypothyroidism. But that's not the universal concept all over the world. Most people believe that these ventricular abnormalities probably are not as common as it is believed to be. It is possible that people with subclinical hypothyroidism in the childhood age may have endothelial dysfunction, and there is increased epicardial fat thickness, which are surrogate markers of atherosclerosis later on in life. There may be some altered change in the lipid, in the sense that there can be low HDL and high triglyceride, suggestive of an element of insulin resistance that may accompany the subclinical hypothyroidism for a long period of time. And if we measure the insulin resistance in a person of a children with subclinical hypothyroidism, sometimes it turns out to be a little high. There is attention level and verbal fluency, which is part of the cognitive function, is usually not affected with, whereas growth and bone density has found to be not at all affected in a situation of subclinical hypothyroidism. So with these concerns with subclinical hypothyroidism in children, let us go ahead and find out what can be the reasons behind subclinical hypothyroidism in kids. Well, the predominant reason for having subclinical hypothyroidism in children is something which is akin to adults. That is, the commonest cause is Hashimoto's thyroiditis, which probably is the most common cause. But we must also remember at this age group specifically, there can be some diseases which are not usually seen in adult population, or at least encountered mostly in the children population. We can have mutations in the TSH receptor. We can have dual oxygenase 2 mutations. We can have some syndromes like Down syndrome, Turner syndrome. And it can also be because of this subclinical hypothyroidism, can also be because of persistent neonatal hyperthyroidropinemia or excessive TSH that we see pari-passu with the just after being born. So the neonatal increased TSH surge might continue for some more period of time and probably had gone into the stage of subclinical hypothyroidism in children. Obesity is rather quite strongly associated with subclinical hypothyroidism, but it seems most to be a most to be because of its sequelae rather than a cause. So obesity as such is not the cause, but may be a sequelae of having a suboptimal hypothyroid, thyroid function status. Iron deficiency anemia is also associated with subclinical hypothyroidism in children. It can also be seen in nephrotic syndrome because of the urinary loss of free and protein-bound thyroid hormones. Iodine deficiency or excess, both of which are not very common these days, at least in our country, except in some pockets in some areas of the country, can also lead to a subclinical hypothyroidism and overt hypothyroidism as well. Ionizing radiation for some usage in the childhood malignancy can also lead to subclinical hypothyroidism. Some medications like amiodarone or interferon alpha used for appropriate reason can also lead to hypothyroidism, including subclinical hypothyroidism. But we must also be aware of the fact that it can jolly well be a laboratory pitfall. Actually, it is not a subclinical hypothyroidism. It is basically a macro TSH, that TSH associated with the IgG, and which is less frequently cleared from the body or the serum. And that's why this macro TSH can lead to an erroneous increased level of TSH that is seen, which is certainly not bioavailable. There can be problem associated with excessive ingestion of biotin, which can interfere with the measurement technique. Similarly, anti-streptavidin antibody or anti-ruthenium antibody or heterophilic anti-TSH antibody can also lead to pitfalls in measurement techniques and laboratory techniques, and can erroneously lead to a diagnosis of hypothyroidism, including subclinical hypothyroidism. Euthyroid 6 syndrome is a situation where the TSH level undergoes a complete change, may be elevated, sometimes depleted in situations of some critical care illness. Idiopathic subclinical hypothyroidism is, of course, the reason for exclusion, and we must also be aware that TSH undergoes a circadian rhythmicity and can be measured in situation where it is shown to be a little higher than it is otherwise. If we look into the natural course, and if we categorize people into 4 groups, one who have got a normal TSH level, one who have got slightly elevated TSH level to the tune of more than 5.5 to 10, or somebody who have got elevated and decreased in the proper sense, more than 10 or less than 3.5 respectively. And if we follow them up over, say, 5 or 6 years, we'll see if we are following this group, this is our point of concern, subclinical hypothyroidism. This is normal to begin with. They remain normal throughout for the 5 years or so. And if we follow this particular group, we'll see that people who were having a very high level of TSH or moderately elevated TSH to begin with time, this is the normalcy achieved. So nearly 70 to 80% of them attain normalcy with time. So most cases normalize spontaneously. And in contrast, these two, they remain in an abnormal zone in a situation. Otherwise, we'll see that in a situation of this subclinical hypothyroidism, they go into a state of euthyroidism with time. What are the determinants of TSH variation? Once again, if we categorize people into 3, the children group into 3, the first group is TSH who's less than 5, that is normal. We'll see that with time, even if their TSH was slightly elevated or still within the normal range, their TSH will also undergo a little decrease with time. People whose TSH is between 5 to 10, normal free T4, and your thyroid TPO antibody is positive, this group will see that their TSH is slightly elevated and probably can go down naturally with time. In contrast, people who have got a slightly elevated TSH and a positive TPO antibody will show and elevation of TSH with time. So this is the group where you need to concentrate, and that is why of the three group whose TSH is normal and TSH is moderately elevated with a negative TP antibody, this particular group will show a complete increase in TSH with time, and therefore would need a treatment with, on diagnosis. There are some specific risk groups that we know of, like children with type 1 diabetes, which is associated with development of hypothyroidism later on in life, people who are obese, or people who are Turner and Down syndrome, or families with thyroid disorders. They are the risk groups, and they need to be followed up very carefully. And if we look into the workup of subclinical hypothyroidism, we of course have to look into the birth history, family history of autoimmune disease, some genetic disorders, history of radiation, some drugs, as we have said, iodine excess or symptom of hypothyroidism is there. On physical examination, most important is presence of goiter. We also have to look for signs of hypothyroidism, other signs of hypothyroidism, or other syndromic features. Investigations, routine laboratory test, follow-up thyroid function test. Thyroid antibody is something that really needs to be looked into. Very rarely we'll have to go for thyroid ultrasound or lipid profile. What are the clinical features? They are usually asymptomatic. There may be subtle signs. When to suspect? If somebody is obese, there is a developmental delay or familiar personal history. In the diagnostic workup, once it is completed, we'll have to think of treatment in the sense that children with subclinical hypothyroidism TSH more than 10, irrespective of the etiology, certainly needs a treatment because they are what is known as a overt hypothyroidism. Else, with subclinical hypothyroidism TSH between 4.5 and 10, in the presence of goiter, or in the presence of symptoms, or in the presence of Hashimoto's thyroiditis, or syndromic children, or genetic etiology, or very rarely thyroid node, presence of thyroid nodule, we have to think of the increased risk of progression to overt hypothyroidism, and they really need to be treated at any point of time. Interpretation of laboratory, we'll have to use age-appropriate TSH ranges, as we have seen, and follow the trends over time, not on one isolated values. So if we combine everything together, we'll know that somebody whose TSH is more than 4.5, we recheck after 4 to 12 weeks. If the TSH is, so to say, becomes normal, you forget about the situation, it's a transient subclinical hypothyroidism. If the TSH is high and the FT4 is low, this is overt hypothyroidism and needs to be treated, and of course treated with levothyroxine. If, however, the TSH is 4.5 and FT4 is within normal range, we think of this situation, we'll have to look for history of neonatal hyperthyroidtropinemia, autoimmune and genetic disorders, medications, iodine deficiency, presence of goiter or obesity, anti-thyroid antibody, etc. And once we determine whether this is autoimmune part or non-autoimmune part. If it is autoimmune, TSH is between 4.5 to 10, we can follow every 6 months. And if there is goiter, we have to start treatment with levothyroxine at the very first issue. If the TSH is more than 10, of course, we'll have to think of using levothyroxine in the word go. If it is non-autoimmune associated with obesity, we'll try to manage the weight in the sense that we'll have to go for weight loss. Iodine deficiency needs to be iodine supplementation. Medications, offending medication needs to be taken off. Syndromic situation, we'll have to think of, we'll have to think of presence of, autoimmunity in the form of TP antibody or goiter. In such situation, we take a decision to start him or her on levothyroxine. This may be an illustrative case. An 8-year-old girl with incidental subclinical hypothyroidism detected during school screening, and with time we'll see that TSH gradually is going down over 12 months and probably would not need treatment. Watchful expectancy is the word to go. When to treat, we have seen. Watchful waiting is most situation when the TSH is less than 10 and there is no antibody to TP or thyroglobulin. We have to recheck every 6 to 12 months. Levothyroxine therapy, when it is needed, should be started at the dose of roughly 1 to 2 microgram per kg per day, and every 6 to 8 weeks we'll have to remeasure and titrate the level of the titrate the level of the levothyroxine that is needed. Follow up every 6 months, adjust the dosage as is needed. In some special population like Down syndrome or type 1 diabetes patient or Turner syndrome, we have to use levothyroxine earlier than what is needed in other situations. We have to steer clear of controversies of overtreatment versus unclear benefits. Individualized decision making is certainly very important. This is another case of 12-year-old obese boy with fatigue. TSH is 6.2, FT4 is normal, antibody is negative. We'll probably it justified to observe and manage obesity in this situation. This is a 6-year-old girl with Down syndrome. TSH is 7.5, FT4 normal, TP antibody positive. We of course have to start her on levothyroxine. The summary of the key points is subclinical hypothyroidism is often transient. Treatment is not always necessary. It is important to monitor trends and practice recommendation with the individualized management, very frequent monitoring, and avoid unnecessary treatment. We do have a lot of guidelines from various authorities like ESP, American Thyroid Association, Indian Thyroid Society, all have got given a very clear guidelines as to how to approach this situation. I'll stop here, thanking you, and go back to Dr. Ganavi.
Yes, sir. Thank you, sir. Thank you for this very clear and explicit presentation on this much debated topic on subclinical hypothyroidism in children. So moving on to the next session, we have the much awaited session, that is the quiz. So I think most of the students are eagerly waiting to join the quiz as well. So before we proceed, I request the IT team to display the quiz questions. The quiz rules. Yeah. To participate in the quiz, click on the button, the Attend Quiz button given on the screen, which is being live streamed. The quiz will be conducted through a platform called Slido. You are requested to use a laptop for the ease of experience, and the quiz will run for about 5 minutes. The quiz master will display the case or the description of the questions by screen sharing a PowerPoint file. There will be 10 questions. Each question will be available only for 30 seconds with the timer on. And we request you do not refresh the page or go back to the previous page. So moving on, I request Dr. Vijay sir to introduce Dr. Sonali Appaya, a dear friend of mine, who is the quiz master for today's thyroid clinics. Over to Dr. Vijay sir.
Thank you, Dr. Ganavi. I think we had an excellent talk by Dr. Kaushik Pandit sir on management of subclinical hypothyroidism in children. Now going on to the much awaited quiz. So already the practitioners quiz is already done online. So after the quiz is over, this quiz is over, we'll discuss the answers at the end. So today's quiz master will be Dr. Sonali Appaya, who is assistant professor and consultant endocrinologist at St. John's Medical College and Hospital, Bangalore. She has multiple publications in peer-reviewed journals. She's got a second place for oral paper presentation in ESI 2019. She's received ad hoc grant for research project from ESI in 2024 and from Karnataka Endocrine Society in 2024. She's member of various endocrine and diabetes bodies in India and also in USA. So over to Dr. Sonali. Tech team, you let us know when people have joined.
Yes, sir. We'll wait for another minute, sir, before
Yes.
we start. And also,
Sonali, you can share your questions. Yes, Shyam.
I will give the cue, ma'am, when to go on to the next question. So that way we'll continue the quiz, ma'am.
Okay. Thank you,
Can share.
Ganavi, and thank you, sir. I'll just share my slides.
Yes. So you just wait for the quiz to start because people have to log on. They let us
Yes,
know
yes.
when.
Yeah. We'll be on the first slide itself, ma'am. You can go to the slide mode. Yeah.
Yeah.
Wait here, ma'am. We'll wait. And yeah, we'll only display the questions for now, ma'am. We'll discuss the answers later. Yeah. After the quiz. Cool. Let's, yeah, we can start now, ma'am. Yeah.
Okay. Good evening, everyone. So we'll start the quiz for today. The first question would be, all the following syndromes are associated with non-medullary thyroid carcinomas except Cowden syndrome, familial adenomatous polyposis, Carney complex type 1, Sippel syndrome.
Ma'am, next question.
So the next question is, which study paved the way for India's National Goiter Control Program, which was then the National Identification Program in 1962? The Spiti Valley Study, Kangra Valley Study, Nubra Valley Study, and Zanskar Valley Study.
Madam, next question, ma'am.
Beta selective thyromimetics help in the management of dyslipidemia through all of the following mechanisms except upregulation of LDL receptor in the liver, decrease in the formation of LDL particles by inhibiting sterol regulatory elementary binding protein 1, inhibiting CYP7A1 enzyme in the bile synthesis pathway, induce the hepatic expression of ABCG5 and ABCG8, which transport cholesterol into the bile.
Madam, next question, ma'am.
All of the following are true regarding TSH, that is the thyroid stimulating hormone, except TSH is a glycoprotein hormone comprising of 28 kilodalton heterodimer of alpha non-covalently linked subunit. So that is alpha and beta subunits. Leptin increases TSH secretion from central stimulation of TRH. Circulating half-life of TSH is approximately 50 minutes. TSH secretion peaks between 5 a.m. and 11 a.m.
Ma'am, next question, ma'am.
Normal or increased radioiodine uptake are seen in all of the following differentials of hypothyroidism except thyroblastic disease, trophoblastic disease, TSH secreting pituitary adenoma, struma ovary, and resistance to thyroid hormone, that is T3 receptor mutation.
Ma'am, next question, ma'am.
All of the following gene mutations are causes of congenital hypothyroidism secondary to thyroid dysgenesis except PAX6, TPO, TSH receptor, FOXE1.
Next question, ma'am.
Ultrasonographic features of cervical lymph nodes predictive of metastasis include all except hypoechogenicity, microcalcification, cystic feature, or peripheral vascularity.
Ma'am, next question, ma'am.
Next question. All the following are true regarding a normal thyroid gland except there is approximately 250 microgram T4 per gram weight of thyroid gland. The thyroid contains approximately 800 microgram iodine, most of which is in the form of diiodotyrosine and monoiodotyrosine. T4 in a thyroid gland is sufficient to maintain an euthyroid state for at least 20 days. The C cell in an adult thyroid gland are less than 1% of the follicular cell.
Next question.
All of the following drugs decrease thyroid hormone production except tyrosine kinase inhibitors like sunitinib, interleukin 2, perchlorate, alemtuzumab.
Next question, ma'am. Next question, ma'am.
On evaluation in Allen-Hendron-Dudley syndrome, the thyroid hormone profile seen is normal or mildly increased TSH, FT4 normal or low, high FT3. Option B, normal or mildly increased TSH, high FT4, normal or low FT3. Option 3, TSH low, normal or low FT4, high FT3. Option 4, TSH low, FT4 high, and normal or low FT3.
Done, ma'am.
Okay.
Thank you, Dr. Sonali. I think quiz was excellent. And we will discuss the answers for the DM quiz conducted today first. By the time the tech team will collate the results of the quiz and we will announce the winners also. So, Dr. Sonali, you can discuss the answers for the DM quiz first. After that, we will announce the results for the DM quiz.
Sir, we have the
then we
winners,
can
sir. I can
discuss the
show.
practitioners quiz.
Sir, I can show the winners if needed, sir. They're ready.
I think we can discuss the answers and show the.
Okay, sir. Cool. Okay.
So we'll discuss the answers for today's quiz. The first question, All the following syndromes are associated with non-medullary thyroid carcinoma except. So the answer here is D, Sippel syndrome, which is another name for MEN2A, which is classically associated with medullary thyroid carcinoma. So the other syndromes, Cowden syndrome, familiary adenomatous polyposis, Carney complex type 1, Li-Fraumeni, Dicer, CHEK2 mutation. So all these are associated with usually follicular or papillary variant of thyroid carcinoma. The second question, which study paved the way for national goiter control program? It was the Kangra Valley study. So the Kangra Valley study here, they studied initially they tried iodinization of salt and they checked whether this prevented goiter in the Kangra Valley. And once it was further enforced all over India in the national program, which was started in 1962. The third question, beta selective thyromimetics, how they help in the management of dyslipidemia. So of all the option, except was the inhibiting CYP7A1 enzyme in the bile synthesis pathway. The CYP7A enzyme is the rate limiting step in the bile synthesis pathway. So this enhances the conversion of cholesterol to bile acid and helps in the excretion of the cholesterol through the fecal route. So the answer was induce CYP7A1, which is a rate limiting step of the bile synthesis pathway. All the following are true regarding TSH except answer would be TSH peaks between 5 a.m. and 11 a.m. So it doesn't peaks between 5 a.m. 11 a.m. It actually peaks between 11 p.m. and 5 a.m. So it is the circadian secretion peaks during this time. The next question, normal or increased radioiodine uptake is seen in all the following causes of hyperthyroidism except the answer is truma ovary. It is depicted in this slide. So as you can see, decreased or near absent uptake is seen in silent thyroiditis, subacute thyroiditis, amiodarone-induced thyroiditis, iatrogenic or factitious intake of thyroid hormone, and struma ovary. These are some of the causes of near absent radioiodine uptake in cases of hyperthyroidism. All the following gene mutations are causes of congenital hypothyroidism due to thyroid dysgenesis except here the answer is TPO. So this slide depicts the causes of congenital hypothyroidism. It could be due to central cause, that is a pituitary hypothalamic cause. So we are not going to discuss that in detail. Coming to the thyroid causes, it could be due to thyroid dysgenesis where there is abnormal development of the thyroid gland or thyroid dysharmonogenesis where the thyroid gland development is normal but the synthesis of the hormone gets affected by affecting one of the steps in the synthesis like TPO, deox enzyme, SL2 being the SLC5A, that is the NIS channel, SLC26, that is the pendrin. So these steps get affected. Then it is the dysharmonogenesis. If there is mutation in PAX8, TSH receptor mutation, FOXY. So all these mutations result in thyroid dysgenesis where there is hypoplasia or aplasia of the thyroid gland. The next question, ultrasonographic features of cervical lymph node predictive of metastasis include all except the answer is hypoechogenicity. So normally the cervical lymph node is hypoechogenic. If metastasis is present, it becomes hyperechogenic. Other features are microcalcification, cystic appearance, peripheral vascularity, and round shape. So normal shape is oval. When there is metastasis, it becomes round. All of the following are true regarding thyroid gland, normal gland, except there is approximate answer would be T4 in a thyroid gland is sufficient to maintain euthyroid state for at least 20 days. So the answer is it is enough to maintain for at least 50 days. So roughly around 2 months the gland has stored hormone for release. So as a result, in a patient with thyroiditis, usually the thyrotoxic phase lasts about 1.5 to 2 months till the reserves get over. Then after that, the patient may become euthyroid or can become hypothyroid. All of the following drugs decrease thyroid hormone production except, so the answer is alemtuzumab. So this is one of the hormone which actually increases the thyroid hormone production. So most of the newer monoclonal antibodies actually cause decrease or hypothyroidism. So alemtuzumab is one of the only few drugs which cause hyperthyroidism, something like Graves. On evaluation of Allen-Herndon-Dudley syndrome, the thyroid hormone profile seen is. So the answer is option A. Here actually TSH is normal or only slightly elevated, but FT4 is low or it can be normal range, and FT3 is paradoxically high. Why this happens? Because this is a inactivating mutation in MCT8, which is a transport channel in the brain for the thyroid hormone. So it is X-linked hereditary mutation, and usually manifests in males. Here the central hypotonia, peripheral spastic. Uh, so in females usually they don't have symptoms. Uh, they only have elevated T3 and reduced arterial circulatory levels.
Thank you, Dr. Sonali, for discussing the answers. Shyam, we can have the answers for the DM quiz. The prize winners.
Yes, sir. Infa, you can
Yes.
screen share, yeah.
Yes, on it.
Practitioners.
No, this quiz first. DM quiz.
Yeah. So these are the winners.
Today's quiz?
Yes, sir.
So I congratulate the winners for today's quiz. First prize goes to Dr. Priyanka, second prize Dr. Kavya, and third is Dr. Nikhil Sanjeev. You will receive a letter of appreciation from the Indian Thyroid Society by email. Thank you for all the doctors for participating. I'm sure you would have learned a lot from the quiz. Dr. Sonali, you can discuss the answers to the practitioners quiz, and then we can declare
yes,
the
sir.
results of the.
Yeah, I'll just share the slides. So the practitioners will go through the question and answers. So after the Food Safety and Standard Regulatory Act released in 2019, what is the adequate level required in the production and the consumer level and distribution channel of iodine? So the answer is 15 to 30 per molar. So this is has been also elucidated in this ITS expert consensus. All the following ultrasonographic features are suggestive of benign thyroid nodule except cystic nodule, taller than wider, smooth margins, comet tail artifact. The answer would be taller than wider. So taller than wider is a sign of malignancy. So as given in this TIRATS 4 classification by the American College of Radiology, you can see wider than taller is benign, and taller than wide is has 3 points and is more suggestive of malignant potential. In hypothyroidic women receiving LT4 with suspected or confirmed pregnancy, that is positive urinary pregnancy test, the dose of thyroxine to be increased is 20 to 30%. So we say increase by 2 to 3 tablets per week. In a hypothyroid woman treated with thyroxine planning pregnancy, the dose should be titrated to target a serum TSH value between. So the answer is below 2.5 would be the answer. As also mentioned in the thyroid disorders and pregnancy consensus statement by ITS. For Graves' disease, the third generation TSH receptor antibody binding immunoassay has a sensitivity and specificity of 96 to 97 and the specificity of 99%. So it is a very high sensitivity and specificity for Graves' disease. In a woman post-radioactive iodine ablation of thyroid gland for Graves, the pregnancy should be deferred by, the answer is 6 months. So this is given in the radiation safety guidelines by American Thyroid Association. All are true regarding screening for primary hypothyroidism in pregnancy except screening reduces the burden of adverse maternal outcomes. True. Targeted screening is recommended. Serum TSH is the screening test of choice, and screening is advised in the first antenatal visit in the first trimester. So the answer is except targeted case-based screening. By the ITS guidelines, recommend the universal screening of hypothyroidism for all antenatal women in the first trimester, and we don't prefer targeted case-based screening. All of the following are true regarding thionamides except the answer would be equivalent dose of carbimazole, methimaz and propylthiouracil is 40:30:400. So the 40 milligrams of carbimazole is equal to 30 milligrams of propylthiouracil and 400 milligrams of 30 milligrams of methimazole and 400 milligrams of propylthiouracil. All of the following can be seen in cases of thyrotoxicosis factica except the answer would be high thyroglobulin, as there is increased intake of thyroglobulin from in the form of pills from the outside. So as a result, the thyroid gland gets suppressed and TG is in fact low. So this helps to identify cases of thyrotoxicosis factitia. All of the following conditions have similar pathogenesis except gestational transient thyrotoxicosis, Graves' disease, hyperemesis gravidarum, and hydatidiform mole. So all these conditions can present in pregnancy. So the answer would be Graves' disease. In Graves' disease, it is mediated by TSH receptor antibody stimulating and the thyroid gland, whereas the other conditions like gestational transient thyrotoxicosis, hyperemesis gravidarum, and hydatidiform mole all are mediated by HCG, increased HCG production, which binds to the TSH receptor due to the crossover specificity and can result in increased thyroid overactivity. Thank you.
Thank you, Dr. Sonali. Tech team, can you share the answers, like the winners for the practitioners quiz? Congratulate the winners for the practitioners quiz. Dr. Prabhuram, first prize, Dr. Kalaivani, second prize, and Dr. Vaishnavi, third prize. You will receive a letter of appreciation from the Indian Thyroid Society. I thank the quiz master for today, who has prepared an excellent quiz. It was very educative, and as she highlighted, most of the topics are already discussed in the Thyroid Research and Practice Journal, where excellent review articles have been published and latest studies and updates are there. So I request all the postgraduates and all delegates to go through the Thyroid Research and Practice Journal, which is an open access journal. Over to Dr. Ganami.
Thank you, sir. Thank you, Dr. Sonali, for leading such a very insightful quiz session. So as we come to the end of today's session, I'd like to invite Dr. Pramila Madam to share the closing remarks.
Yeah, thanks, Dr. Ganvi. I think we had a nice discussion, starting with the case discussion on thyroid nodules and moderated by Dr. Amit and Dr. Swati, and Dr. Suprabha presented the case. And then after that, we had an excellent talk by Dr. Kaushik on subclinical hypothyroidism in children. And the quiz, as usual, was the best again. And Dr. Vijay Bhaskar Reddy moderated it, and Dr. Sonali did an excellent job. Now, only thing is, like, I would still request all the DM residents to please participate in the quiz and tell to your peers as well that the ITS quiz is there, and you will get a certificate of appreciation from ITS if you win the quiz. So please participate in the quiz, because that's we put these questions for you people only, so that you can benefit from the quiz as well. So please communicate and give more information to your peers, to your contemporaries who are doing DM at other places, so that they can participate in this ITS quiz. And this is an official quiz by the Indian Thyroid Society. And I also request more practitioners also to participate in the practitioner quiz as well. And as Dr. Reddy has already requested, that please send your articles to Thyroid Research and Practice, which is the official journal of the Indian Thyroid Society. So please send your articles to the Thyroid Research and Practice journal, so that you can get more visibility as well. And please submit your abstracts if you're working on thyroid for the ITS conference. The abstract submission portal is on, and you can submit your abstract to the Thyroid Research and Practice Journal. That is, your abstract will be published as the conference proceedings. You don't have to publish your full article for sure. If you want, you can definitely send it. And this will be published in the proceedings of the conference. So the conference is in August. So we have opened the portal for abstract submission for ITS Con. So please, if you have any research which you're doing on thyroid and you want to showcase it, present it in the ITS Con, Indian Thyroid Society official conference, which is going to be held in Mumbai, please submit your article to the ITS conference abstract submission portal. So with this, I hand it over back to Dr. Ganvi, and she will continue forward from here.
Yes, ma'am. Thank you, ma'am. We hope this session on the management of thyroid nodules and also subclinical hypothyroidism in children and the quiz questions have been quite valuable and informative as well. So our next thyroid clinics is scheduled for July of 9th. We are eager to host one and all for this session again for the insights on thyroid health. So thank you all for joining, and we look forward to seeing you the next time, that is on July 9th. So with that, we conclude. Thank you. Thank you, one and all.
Thank you.
सर्वमिदं विभाति